Welcome. It is noon, so I think we'll go ahead and get started. I know people are still slowly coming in, but we will let them come in while we are doing the introduction. My name is Axel Adams. I am the manager of the Fairbanks Center for Medical Ethics. We're really glad that you're joining us remotely again today. We hope to be back in person soon. We'll always continue to offer our lectures virtually, but you will hear from us by February 16th about our March 2nd lecture, if that will be hybrid or in person, or just virtual. So as COVID continues to spread, we just want to continue to say thank you and express our appreciation for the frontline workers who are continuing to work exhausted. So we just want to remind you that while we are masters of Zoom, we know that there might be technical issues. So we just appreciate any patience of anything that happens during the lecture today. The webinar is being recorded. It will be available on our website, which is fairbankscenter.org, within the next week or so. And the recordings are eligible for continuing education for 30 days and for continuing medical education for a month. So we encourage you to send this information and this lecture to your colleagues. You will receive a link for the evaluation tomorrow at the email address that you used to register. We encourage you to fill out the evaluation, even if you don't need the credit, because it helps us track our attendance and allows you all to provide feedback. And the Q&A box is available to post questions. However, we will not be responding to most questions until the end of the presentation when Dr. Helft is ready to respond. And Dr. Helft has no financial conflicts of interest to disclose. So I first want to provide the official introduction that Paul gave to us. So Dr. Helft is a native of Indianapolis and born at the IU Health Methodist Hospital. Dr. Helft completed his undergraduate degree in general studies in the humanities and his medical degree at the University of Chicago in Chicago, Illinois. He then went on to complete his internship, his residency, and his fellowship in hematology and oncology and clinical medical ethics at the University of Chicago. Dr. Helft joined the faculty of the IU School of Medicine in 2001, where he is currently the Allan S. Manalan and Diane K. Werth Professor of Medicine in the Division of Hematology and Oncology and an Adjunct Professor in the Department of Surgery. Dr. Helft is the author of more than 105 publications and has served on the editorial board of the Journal of Supportive Oncology, Perspectives in Biology and Medicine and Oncology. So that's the official introduction, but I also want to say that today's lecture comes with an extra feeling of gratitude. Many of you know that today, after the lecture, we were scheduled to have an in-person celebration of gratitude for Dr. Helft, and that celebration has been postponed. Please do watch out for the invitation for that to come later. We still want to express our great gratitude towards Dr. Helft. Paul is stepping down as the director of the Fairbanks Center for Medical Ethics and the vice president of clinical and organizational ethics effective March 1st of this year. But his journey with us has been long and so fruitful. In 2004, he became the first director of the Charles Warren Fairbanks Center for Medical Ethics and went on to build FCME and the Department of Clinical and Organizational Ethics into what it is today. He developed all of its programs, including the Fairbanks Fellowship in Clinical Ethics and the program in Nursing Ethics. Under his leadership, we have seen 114 ethics fellows graduate. He has impacted so many lives through his work in clinical ethics that he will indeed leave a legacy. We are so thankful that he will continue to serve as a faculty member at FCME and teaching some of our core sessions to our ethics fellows. He is not leaving IU Health, just transitioning away from his official role with us. And Dr. Helft, it is with a grateful heart that I turn this lecture over to you.
Well, thank you so much, Robin. And as many of you know, I have a feeling many friends are in the audience, and Robin is a hero of mine. So let's move on to the lecture with that nice introduction. I have no conflicts of interest for this lecture, and I just wanted to take a minute to send out some thanks as I plan to step down here in a month. The first is to Stephen Ivey, whose vision and first grant actually founded the Fairbanks Center for Medical Ethics in 2000, and also to Kevin Armstrong, to whom we report, who's been an extraordinary advocate for us. I want to thank all of my Fairbanks Center colleagues, past and present, who have taught me enormously, and I benefited from all of those relationships. I want to thank many, many colleagues at IU Health, IU School of Medicine, IU School of Nursing, the IUPUI community at large. I want to thank my students and residents and fellows and other learners from whom I always learn much. I want to thank most of all my patients, past and present. They have been my greatest teachers. My division that's allowed me to engage in this work for the past 18 years. And most importantly, my family, my children, Graham and Margot, and my wife, the love of my life and my partner of 27 years, Melissa Cavigan. So there they are. So just briefly about my medical practice, I've been in academic practice for 20 plus years. So this was my first job out of fellowship training here at IU. And my entire practice is limited to the treatment of gastrointestinal cancers. Digestive cancers are a complex group of cancers affecting all of the organs of digestion, but my own patient population makes up about 50% colorectal cancer patients, that's the most common disease, 20% neuroendocrine tumors, and 30% a smattering of other organ systems, pancreas, esophagus, small intestine, etc. But importantly, about 85% of my patients have a life-ending diagnosis, meaning that they will go on to die of their illness, which has always been of great interest to me, both personally and professionally, in helping patients to make those transitions. So I'm just going to start with a case. This is a composite, obviously, not a real person, but typical of somebody that I might see in a given week. A 41-year-old woman who is completely healthy. She develops rectal bleeding and some pain over a period of a few months. And her evaluation and workup leads to a diagnosis of rectal cancer, metastatic to both liver and lungs. She's actually a nurse practitioner by training, so highly medically involved and works in a leadership role at a biotechnology company. She has 2 adopted tween kids, and she comes to see me for her initial oncology evaluation. So this talk today is going to be about some things that I've learned and practiced and honed in how to talk with, communicate with, and speak with patients like this. So these are her imaging studies. She has disease in her liver, outside of her liver, and in her lungs. And most importantly, that means that she has an incurable disease. So there are many challenges in talking with such a patient, especially in the very first encounter. And I just wanted to name, without going into a lot of detail, the sort of communicative and relational dimensions for the first few encounters that every clinician in this setting faces. So on the patient's side, they almost always come in with extreme emotion, especially after diagnosis. They're trying to process a great deal of information and cognitive content. They have autonomy, and many of them want to be very involved in decision-making. They have family concerns. Often they will tell you that that's their primary concern. They have an instinct to protect others from this hard information. Many of them feel that they've failed their loved ones for having acquired a disease like this. They have fear of suffering, which they almost never want to talk about at the beginning. They have a sense of self, which has been vastly disrupted by the diagnosis. And they have other concerns around work, career, finances, etc. So walking into the room as a clinician, I have many tasks to face, as many of you know, to establish rapport and a relationship, to assess information needs, to transmit information, to recognize and support emotion if possible, to demonstrate empathy, to manage emotion that comes out both from patients, family members, and maybe oneself, to lay a foundation for a strong relationship going forward and in the future, and to establish trust and to manage one's own emotion, which is difficult sometimes, as all of you who practice know. So how much information does this patient want? You would make an assumption about her based on her medical background that she wants lots of information. And it's important to remember that patients and family members under this amount of stress don't process information normally. Stress actually interferes with information acquisition, processing, and practice. There are really hundreds of studies about this, which I will not go into. But importantly, it would be important to assess one's information preferences. And studies have found that doctors don't routinely do this. In other words, we don't figure out by asking questions how much patients want to know. The frequency of such assessments in clinical encounters has been shown to be low. And very importantly, it's important to remember that information preferences don't always equal decision-making preferences, which is to say that very simplistically, some patients who might be high information people don't want to be involved in a decision. They want to leave it up to their doctor or their family, and so on. Some low information patients actually want to be very involved in the decision-making, despite the fact that they don't want much information. So you could generate a sort of 2x2 table around this concept with everything in between. So you can see how complex it gets. Studies looking at how much information cancer patients want almost all show that cancer patients want all of the information all of the time. And so there are dozens of these studies by now. Many of the studies in the first couple of decades of this research actually suffered from in a sense, a fatal flaw. They included both curable and incurable cancer patients. And it's very clear that patients who have curable disease acquire, process information differently from those who are given a life-ending diagnosis. And also another complexity that one has to manage in speaking with patients is that information preferences vary by individual. They vary over time. One might want lots of information at the beginning or none at the beginning, and develop information hunger later on, or vice versa. They're often based on family dynamics and the need to protect oneself or one's family members from this very hard and emotionally charged information. I always say that cancer patients never come to their clinic visits alone, and if they come alone, we wonder if something's wrong. They can't be reliably predicted from demographic, cultural, or cancer-specific factors. This has been shown in studies. And the effects of low-quality communication may actually be magnified by implicit racial bias in racially discordant doctor-patient relationships. This is an area of research that colleagues at the University of Rochester and other places are doing, which is very interesting. So the patient might ask the question, how long have I got? And patients don't always ask this question. Family members might ask it for them. They might not ask it at all, but they often ask it obliquely. They might say something like, what about time frames? Or what have you seen with patients like me? And I usually stop those questions after hearing them and ask a couple of clarifying questions. Something like, it sounds to me as if what you're asking is what your prognosis is or how long you have to live. And I'll make sure that that's the question that they're asking and not something else, and also that they want the answer to it. So it turns out this is very important, especially for patients with serious illness or life-ending illness, because prognostic understanding has been shown to influence treatment decisions in a very large body of research going back several decades. These are two older studies which demonstrated that patients who understood their prognosis was limited were much more likely to choose, let's say, palliative care, end-of-life care, or best supportive care over anti-cancer therapy. There is evidence that prognostic communication is inadequate among oncologists. My larger body of colleagues, and these are just a few examples of these studies showing that, for example, cancer patients receiving palliative chemotherapy only report that prognosis was discussed about 40% of the time. And others have done this. Now, whether patients actually don't remember this, whether this discussions happened, whether the oncologist thought that they were having a discussion or not, those are other questions. But nevertheless, it's very common in studies to find that patients report not having discussed these issues. What do oncologists say about their own practice? This was work done by my former and first research mentor, Dr. Christopher Doherty, who found that about 40% of oncologists reported that they, quote, always discuss their patient's prognosis because they need to know it. But the remainder did it less often than that. They either ask their patients if they want to know their prognosis or discuss it only if they say yes or ask about it. If you want to measure patients' understanding of their prognosis or estimates of their prognosis, just simplistically, how long do you think you have to live? It turns out that this is quite a difficult thing to measure in research studies. So reported understanding may not actually equal actual understanding. For example, for many reasons, patients may believe contradictory things at the same time. This is a human characteristic. They may believe that their life is going to end from the diagnosis, but they're going to outlive it or beat it because they're the one. They strongly believe that you have to have a positive attitude, even though there's almost no evidence whatsoever that positive attitude is related to cancer outcomes. Belief statements versus factual statements. If you ask a patient, how long do people on average live? That's a factual statement. If they believe that they're going to live much longer than that, that's a belief statement. They may actually disagree with you. Many studies have documented that patients don't always agree with their physicians or don't accept what physicians tell them, and that humans are extremely capable of superstition, magical thinking, and other biases that affect this cognitive understanding. And I won't go through all this, these studies, but therapeutic misconception is extremely common, and many studies have documented that patients often believe that they're going to be cured by their therapies when they're only undergoing therapy to prolong life. The study after study, even recent studies in the late teens, 20 teens, continue to show this evidence of widespread therapeutic misconception. I think that we were the first group to study oncology nurses' perceptions of how oncologists communicated about prognosis and other end-of-life issues. This work was actually done by our former fellow and cancer center nurse, Maggie Urich, during her fellowship. And she published this work in the Oncology Nursing Forum in 2011. But she found when we asked oncology nurses their perceptions of the doctors that they worked with, about a quarter disagreed or strongly disagreed that the physicians that they worked with were skilled at prognostic communication. And so you can see that they had a fairly prevalent set of negative impressions of the doctors with whom they worked, between a quarter and a third of them not doing a very good job at this. So how do we talk about prognosis to the patient? So go back to my patient at the beginning, 41 years old, extremely upset, has a lot to live for, very young, completely changed in her sense of identity. She feels in crisis. So I always start by first clarifying whether they're actually asking the question I think they're asking. And then I always say that I have a long answer to that question. And here's some helpful ways of framing this. We don't want to avoid the question, but we also don't want to give a simplistic or a blunt answer to this. So no one can predict with certainty. This turns out to be true. I'll show you some data later. But if you've practiced for a long enough time, you realize that you're wrong some of the time. Even experts are not accurate, especially at the outset, at the very beginning of a diagnosis, when you haven't been able to tell what the pace of the disease is. One helpful framework for talking about this to a patient, that is at the outset giving them some more specific information, is to talk about average, best, and worst case scenarios. What is an average patient? What happens to them? What's the best case scenario? What's the best you've ever seen or could imagine in this case? And what's the worst case scenario? I think that helps to frame an answer. I think it's also, I have found it useful to say, do you want me to talk plainly and honestly? And the reason I found this phrase helpful is, why do we offer honestly? Why, of course, we're going to be honest. But one, it sends an implicit message that there's bad news coming. And there are multiple studies documenting the fact that patients receive bad news better when they've received a warning of some kind. And this serves partly as an implicit warning. And then patients, I think, experience this permission statement as a sign of respect for their feelings. So instead of just being blunt or blurting it out, I asked if they want me to talk plainly and honestly. They almost all say yes, of course, but I feel like they've experienced this as a sign of respect. So how accurate are oncologists? Well, this was a story from the physician and decision scientist, Peter Bubel. He says, while I was in residency at the Mayo Clinic, my oncology attending arrived for rounds one day with a sheepish grin on his face. It was June 3rd, and for the 7th straight year, a former patient of his called him and angrily exclaimed, "I'm still alive, you idiot," before slamming down the telephone. 7.5 years ago, the oncologist had given the man 6 months to live. And all of us who've practiced a while have a patient or two or three or a dozen, I at least have a dozen, where I've vastly underestimated their prognosis, and we remember them. And hence the Spanish proverb, it's better to be given 6 months by a doctor than by a judge. So how accurate are we? This is the largest review that I know of about prognostic accuracy. This is a set of studies that were actually already in some ways biased because they were studies of hospice patients and or inpatient palliative care units. So these were patients for whom a prognostic decision had already been made. and who actually had a very poor prognosis where we would think we would be more accurate. But even in that group of patients, we're not within 4 weeks, we're outside of 4 weeks in about a quarter of patients, and only within 1 week in a quarter of patients. So you might ask, how accurate does one need to be? Do you have to send the message of a specific date? Is it accurate enough to be within a week or a month or 3 months? But this is the accuracy data. It's also become clear through multiple studies that oncologists, not surprisingly, are overly optimistic. So about 30% overly optimistic. This is observed survival versus predicted survival in a study of more than 350 patients that a former colleague, Elizabeth Lamont and Nicholas Christakis, did. And you can see those dots above the line show that we're overly optimistic by about 30%. This has been a consistent finding across multiple studies now, with that research having been reproduced and demonstrated in multiple studies. So another useful phrase that I find for a patient at the outset, especially who I would expect to live a year and a half or 2.5 or 3 years, or even longer perhaps, it's too far over the horizon to see for now. And that I think allows a little bit of uncertainty at the very beginning when it's not, when we're not in desperate circumstances or needing to make an end of life care decision. And so I and others have argued that the amount of conversation devoted to prognostic and end-of-life issues on that third model, this is a set of simplistic models of how prognostic communication happens. The top line shows you the reputation that oncologists have, that patients are diagnosed, they perk along, and at the very end, we dump the truth on them. Palliative care specialists have reminded us to be clear about prognosis throughout the trajectory of illness. That's in the middle panel. And I and others have argued that it's okay for it to come out with time as patients experience their illness, get sicker, and have other events that remind them that death from cancer is an inevitability. This patient has a prognosis of probably a median survival predicted of around 30 to 36 months. And so, you know, that is not immediately over the horizon. Certainly it's very short for a patient who's only 41 years old, but I do not feel on the basis of her diagnosis that she needs to have, you know, the fear of God put into her, so to speak, at the very outset. And so this leads me to the most difficult communicative task and problem that I've struggled with since forever, but since I've been a young oncologist, now an old oncologist, and that is how to balance accurate and useful information with hopefulness. As humans, we generally don't want to be the last person to have dashed the patient's hopes once and for all. But how to balance this in a single conversation or across multiple conversations, I think, is one of the greatest communicative challenges that we face. So often, either in the middle or towards the end of a visit together with a patient like this, I'll stop for a second and just say, how are you doing with all of this? And I have found that people almost all understand exactly what I mean by that. They know that I mean emotionally. And I can't see all of you in the audience, but almost all of you will predict that what happens when you stop and ask this question is that the patient begins to weep, usually. And they'll sometimes put on a strong face and tell you that they're doing okay. They might say something reassuring for their family members. They might break down and cry, and at that point become highly emotional. So how often do physicians do emotional assessment in medical encounters? In observational studies, physicians, it turns out, inquire about emotional well-being in a minority of interactions. Some studies down in the single digits of interactions. Studies have not really found, there's a really interesting body of research around gender differences, but they have not really found that there are gender differences evident in the amount, the quantity, or the manner of biomedical information giving or social conversation. So if you're presenting statistics or talking about treatments or side effects, or checking in with how a person is doing at the outset during greeting, no real gender differences. But in meta-analyses, female physicians engage in significantly more active partnership behaviors, positive talk, psychosocial counseling, psychosocial question asking, and emotionally focused talk. So I find that this is a very interesting finding in gender differences in female versus male physicians. So back to the question, how are you doing with all of this? I have found this question to be helpful in a number of ways. One is it is a good opportunity for emotional check-in that wouldn't necessarily happen otherwise. Two, I find it's a great opportunity to create bonds. Almost everybody, I think, remembers that you asked this question. I have found it to be an extremely good way to engage and form relationship with patients. So what do you do when the patient starts to cry? So this is a set of behaviors that I have, I guess, honed over the years. I don't know if I'm right about all of it, and I'm sure many of you experienced clinicians have your own ways of managing the room when a patient starts to cry. I have noticed in observing others in these circumstances, and learners in particular, that one of the things that happens is that we clinicians get really nervous, and that anxiety and nerves, which happen at the site of strong emotion, affects the interaction. Oh, so here's my advice, and you can take it or leave it, and I'd be glad to have feedback or pushback about any of this. So the first thing is to notice that it's happening. It's a little harder with masks on, but by now, oncologists, as you probably can imagine, give between 10 and 30,000 episodes of bad news in a career. So we do this a lot. And so people weep and cry in our offices a lot. But at the first signs of it, stop talking and notice it. And I will just stop talking, and the patient will always notice that I've noticed. And then I'll, run through my nonverbals. Am I sitting in a good position? Am I near enough to them? Am I turned away from them or toward them? Where are my hands, etc.? What's the look on my face? And then my recommendation is just to sit in silence. So when they start crying, to stop and then sit with them and adjust your body language. The longest I've ever done this was about 15 minutes in silence. Most patients become very uncomfortable having somebody watch them cry quickly. You have to decide where to look. Some people want to be looked at while they're crying, and they'll look straight in your eyes back to you. Some of them don't want you to look at them, and you can usually tell. You can stare at your shoes while they're crying and wait for them. Sometimes I'll look to my shoes and then back up at them, back and forth. Touch is a good thing to use if you're good at it, if it feels right in the moment. Mostly not, though. Honestly, I don't think this is a great time necessarily to use touch, maybe afterwards. Family members who then become uncomfortable will often break the silence for the patient. And I'll usually look over at them and acknowledge that they have asked a question, and then look back at the patient, and they'll get the nonverbal message that I'm waiting for the patient to speak. And then I'll let the patient break the silence. And at that point, I'll try to check in, not, to necessarily to name the emotion. You could name that emotion, but I'll say something like, what was it about what I said that made you the most upset? And often it's surprising to me what they said. And I'll learn something new about them and about their experience of their emotional experience of what's happening to them in their illness in that moment. I have a theory. I don't like to get tissues. I've noticed that when people start to cry, one of the first things clinicians do is get up and they look around the room for tissues, which I, number one, find disruptive. And number two, I think it sends an implicit message that the patient should stop crying and clean themselves up. So I don't offer tissues. Most oncology rooms have them in there, and if the patient wants them, they'll usually see them, or a family member will get them. But I don't like to hand them tissues because, again, I think it sends the message that they should stop crying. And so unless the snot is really pouring down or they ask for tissues, I'll just wait. All right, let's change gears for just a second. I'll give you a few different scenarios and some thoughts about how to manage them. So what if the patient actually only has limited metastases? So for example, this patient with, let's just give her locally advanced rectal cancer and oligometastatic disease in her lungs. So she just has 3 lung metastases. So patients with this pattern of disease overall have a cure rate that's as high as 20%. I would say realistically between 10 and 20%. So the risk of recurrence, if you were to remove all of this surgically, is about 80% or higher. So how should we then talk about this complex decision to pursue curative intent treatment in a patient like this, who doesn't immediately obviously have a life-ending disease, although if you were going to bed in Vegas, the probability is that she's going to have a life-ending disease or a life-ending. So she's going to ask the question, something like this: can't we just take everything out? And even patients who have widespread disease, who can never have surgery, ask this question. So this is a complex topic, and whenever I introduce a complex topic, I always start by saying, I'm going to talk like a lawyer for a minute. And nothing against all of my wonderful legal colleagues, some of whom I think are probably in the audience today. But I find if I just pause for a second, it helps to refocus, asks them to pay a little bit closer attention for a moment, and then helps to introduce a complex topic that's going to require some extra attention to understand. And the reason for that is that the way people understand metastasis is not really the way metastasis happens. So on the left-hand panel, we won't go through this in detail, is the Vogelstein model of carcinogenesis, where a cancer cell, a normal cell eventually becomes cancer, and then the final pathway is to metastasis. The right-hand panel is the way people commonly understand cancer, that it goes from stage 1 to stage 2 to stage 3 to stage 4. And that's when it spreads, but that's actually not how it happens. There are actually multiple theories of metastasis, none of which have definitively taken hold. The first one, the oldest one, back in the 1880s, was from Paget, after whom we named Paget's disease, who proposed the so-called seed and soil hypothesis. That is, that the seeds of the cancer spread, found soil in other areas of the body, and landed there. But then, and that's partially true, it turns out actually that cancer cells carry the soil with them, meaning they often carry parts of the tumor that allow them to establish metastasis in other places. And these clumps of cells, which are called micrometastases, then often become dormant, and we can't see them and we can't detect them. And at this point, we don't have a way to know, where they are and how many of them there are, but they happen early. So if the cancer is programmed to spread, then it happens early, and the metastases are either there or they're not there by the time a patient's diagnosed. So back to my patient with 3 lung metastases, she has 3 that we can see, talking like a lawyer, 3 that we can see, but we don't know if there are others. So the helpful terms that I have found to use in this circumstances are to talk about the seeds of the cancer. Everybody can picture the seeds in the soil. We can talk about them being asleep and not waking up yet. When they wake up, then we can see them. I always say that for people who are over 35 or 40, that we don't have a Star Trek scanner. We can't look at every cell in the body. Younger people sometimes don't understand that reference, and that the cancer in general is not thought to be still running around, meaning the metastasis is not still happening. Metastases are not happening as we speak, which is what patients lie awake at night thinking. So my question, can we cut it out? The answer in this patient, especially a young, healthy 41-year-old patient, is absolutely. And we do that with the goal of providing her with that 20% chance of cure. And that, most patients are willing to undergo almost anything for that chance. So changing gears again, let's just give the patient at this point really imminently or more imminently terminal cancer. So her liver now looks like this, with her liver almost entirely replaced with cancer. This would be about 90 to 95% replaced. And I think it's helpful, and all of you who work in the field of oncology or related fields know that cancer patients in general have what I've called an ambulatory phase and a terminal phase. So the top panel schematically might be a patient with colorectal cancer, prostate cancer, breast cancer, whose ambulatory phase, where they're coming in and out of the office and doing well and taking treatment or waiting for recurrences, might be long. And then at some point they turn the corner, and all of us who've seen these patients, hundreds of times, recognize it immediately. They might come in a wheelchair for the first time. They might have trouble getting from their car to the clinic. They look a little sallow. They have some temporal wasting. And you can tell that they've turned that corner into what I've called the terminal phase. This trajectory might be very short in a patient, let's say, with pancreatic adenocarcinoma or esophageal cancer. what if you are in a patient like this with more imminently terminal disease? What if you're the third or the fourth opinion and the patient has come to you because they don't like what they've heard previously? So we at the Cancer Center, as a referral center, obviously see lots and lots and lots of second and third opinions. Roughly, depending on the group, there are roughly 40 to 50% of patients that we see are actually second opinions. So what if you're the third or fourth and the patient doesn't like what they've heard and says something like this: everyone we've talked to has told me that I'm going to die. So that's why I'm here, because I know there must be a way. I don't want to hear any more negative. So they've just told you something extremely important about their information preferences, in a way, that you are going to have to contend with and sort out during this encounter. So I don't know if she's on online today with us, but I want to thank Dr. Shelley Johns for teaching me this and helping me to understand what is called in psychology avoidant coping. So there's been 50 plus years of research on avoidant coping, and the term is used, broadly speaking, to mean things like denial, wishful thinking, escapism, withdrawal, distancing, distraction, minimization, as a way of coping with stressful, emotionally charged information. Hager and Orbel provided sort of a more concise definition by saying that this was cognitive or behavioral attempts to ignore or avoid the existence of a problem or illness. Now, true denial, in my experience anyway, is rare in cancer patients, meaning, denying entirely that I have cancer, that I'm ever going to die. People may say things that suggest they're in denial, but those are often just part of this avoidant coping mechanism that many people use. Some patients want all of the information all of the time, and some don't. Another way of referring to this psychologically is monitors and blunters. So monitors are those patients who look everything up on the internet by the time they've gotten there, and blunters are people who, shut it off because it's too stressful to do that. So why is this important? One of the reasons is that there's evidence that roughly a quarter of cancer patients still have a low quality or a lower quality end-of-life care experience. And in this country, we still have very late hospice enrollment, and the period between hospice enrollment and death has actually been declining for the last couple of decades, meaning we're referring patients later and later. So in recent studies, half of patients who were referred to hospice die within 3 weeks, and about a third of them die within 1 week, probably not long enough really to take advantage of their time away from anti-cancer therapy and to take advantage of the supportive care provided by hospice programs. And 95% of people say they want to die at home. And so getting people, home and out of institutions and so forth. Families' perception of late referral is associated with lower satisfaction. So if they don't get that time to benefit from the things that hospice care, end-of-life care, memory making, etc., much lower quality end-of-life care experiences. So my colleague, Tony Anthony Bach, who is one of the, I think, greatest scholars of oncology-related communication, and Bob Arnold wrote, they've written many things about this, but this is an article about dealing with a patient that doesn't want to know. So his approach in outline form goes something like this: try to understand why the patient doesn't want to know. Acknowledge their emotional distress. Try to make a private assessment about whether the information might change important or pressing decisions. Are they going to die this week? Are they going to die, tomorrow, or is it going to be another couple of months and they have a little bit more time? You can outline the options for discussion. We can talk about this in very minimal ways. We can talk about it in more detailed ways. Help me understand how you would like to talk about it. And then you have, and I added this, but you need to allow space for the patient to decide. In other words, you don't need to ask necessarily or press them into a decision that day. And I've always found it helpful to specifically say, we don't have to make a decision today. Again, if the patient isn't dying today or tomorrow or next week. So I've referred to my strategy in patients like this as the dangle. So dangling information in front of them as a way of managing the tension that they walk in with, hoping that you're not going to say anything negative. And so I'll start something like this. I've formulated an opinion about your situation. So I'm not telling them, I'm just saying I formulated an opinion. but it sounds as if you've heard many negative descriptions previously, and I don't want to burden you with one more of them if you don't feel prepared to talk about it. Now, why do I couch it in these terms? One, I think that this way of couching it implicitly recognizes that the information is highly stressful. Says you've heard many negative descriptions, that this information is a burden. It avoids being overly blunt, which has been shown in Robert Maynard's studies and other studies to be the worst way of delivering bad news, just blurting it out. And we sometimes get frustrated with patients like this who have heard multiple opinions, heard it multiple times, but don't want to sort of accept it. But being blunt is going to help them accept it, I think. I think it gives the patient a sense of control in what information they want to receive. So again, I'm offering it, but I'm not forcing it on them. And then it sends an implicit warning that bad news is coming, which, as I've mentioned, I've called this forecasting, which is a term I borrowed from Robert Maynard. Forecasting that bad news is coming, a shot across the bow, so to speak, helps patients to digest it. That's been shown cognitively in psychological studies as well. It does rely, this strategy, the dangle, relies on patient families trusting your expertise. So this, I've gotten greater success from this strategy, I would say, as I've gotten more gray hair and older, and in some sense, maybe more expertise and authority to say. But I have found this to be a helpful strategy in patients who walk in telling you that they don't necessarily want to know about their situation. Now, how do you introduce the hospice? So the word hospice, just bluntly, freaks people out sometimes. So if you lead with the word hospice, you have to introduce that term, I think, carefully, not to avoid the term, but rather as a way, you have to find a gentler way of helping people to come to understand. Many people have had experiences where a relative was put in hospice and 3 days later they died. This is because we refer patients all the time to hospice late. So this is an article that I wrote in 2008. I like to use the term hospice home nursing rather than the naked term hospice. And the reason for that is that everybody knows about home nursing. Everybody has a positive view of home nursing. Everybody understands what that is. And that's in many ways what hospice is about. It's about a program of support. I like to call it a layer of support between us and the patients, mostly provided by nurses. So I have left specifically about 15 minutes. I was hoping to get done in 45 minutes and leave some time for conversation to the extent that we can do that. Questions, concerns, pushback, corrections. And I'll just leave you with this quote from a former teacher of mine, Leon Cass, Robin.
Thank you, Paul. So I'm going to have our first question be from Jean Lammers. Jean is an old friend. Jean says, first of all, thank you for a wonderful presentation and for your years of dedicated work. It can take many years for a clinician to reach an advanced level of ability to deal effectively with patients with life-limiting diseases. So what are 2 or 3 recommendations that you would suggest for implementation by providers early in their careers?
And Robin, because I can't see the question, just to be clear, early in their career with respect to what set of skills?
So it can take years for clinicians to reach that, the kind of that communication style that you were talking about, because it comes with wisdom and experience, and you talked about your gray hairs. So how can someone have a couple of ideas or recommendations for earlier in their career?
So I guess 2 or 3 things that I would recommend. One is that, there are people who are naturally good at this. Lots of clinicians are naturally good at this, meaning they are good at reading people. They have, excellent ability to read and interact with people. They're good communicators in the first place. And medical training, in some sense, hones that natural set of skills. There are also people, I would say that the evidence about this is that roughly a quarter of physicians, probably a quarter of humans, my psychology colleagues can correct me if I'm wrong, are missing the module, so to speak. They're missing the module of sort of how to read people, how to read emotion, how to deal with emotion, and they don't deal with it comfortably. There are actually studies showing that you can't train that in physicians. So if you're missing it, it's actually very difficult to acquire it. So you might immediately, number one, sort yourself into whether you're good at it or not. Number two, if you are good at it, then your ability to find points of contact for emotional connection is going to be the greatest skill that you have in taking care of patients. They will be, more honest with you. They will open up more. They'll be more adherent. They will have a better experience. They will report to you that their quality of life is higher, and so forth. So that ability to have touch points of emotional connection would be a skill I would try to develop. And then the last thing is controlling one's own emotions. I mean, especially when I was younger, it was pretty easy to get upset in a patient's room. And I think it's fine to get upset in a patient's room when there's really hard things to talk about. But learning how to be aware of one's own anxieties, distress, sadness, sorrow, etc., is, I think, a helpful thing. So I would get to know oneself and how to control that. Should you cry in a patient's room with them? I have no problem with that. If the crying becomes about you and they're offering you tissues, you probably cross the line.
Zainab also adds, Dr. Salih also says, maybe reading humanities and books written by parents, patients, and then having discussions with colleagues and experts may also help too for those early learners.
Zainab is an expert neonatologist who could teach this.
So I want to ask a question from our Chaplain Williams. Chaplain Eric says, please tell us how this work as an oncologist has spiritually formed you.
Well, I would say in a few ways. That's a difficult question. One is I'm grateful every day when I walk into work that I don't have cancer, and I often tell my patients frequently say, "How can you do this? This must be so hard." And I tell them that every day I walk in and I don't have cancer, and I get to be reminded about how precious life is to say something completely benign or common. So how has it shaped me spiritually? Otherwise, one, it's given me a great recognition, and I wish that I lived this out better, but it certainly has given me a great recognition of the finitude of life. And number two, it's given me great respect for the strength that people bring to their cancer experience. I mean, people willing to undergo all kinds of things that I think I wouldn't personally be willing to undergo. So the amount of strength that I've been able to witness in humans and goodness, sometimes I'm cynical about many things, but the human goodness that I've been able to witness, I think has been food for me.
Thanks, Paul. So Susan Hickman is saying, thank you for sharing your wisdom and your reflection. She says, Paul, how has your expertise in ethics informed your clinical practice?
So those of you who know Susan Hickman know that Susan is an expert ethicist and an expert researcher, among many other things, and a psychologist. So if Susan wants to correct me about any of the psychology that I presented today, please do. My ethics background, I think, has been helpful in a number of ways. One is that the practice of clinical ethics, the central skill of clinical ethics is not so much reasoning, but communicating. So it has caused me to reflect very deeply, I think, on communication. The second is around decision-making. So I frequently encounter patients that have to make very difficult decisions that they are not in any way equipped or prepared to do, meaning decisions which require enormous trade-offs between burdens and benefits of treatment. And they may have no experience making these decisions. And so my desire to walk that decision with them in a way that is both helpful to them, that respects their autonomy, and at the same time, fulfills their need to have some paternalism in the decision, or some help and guidance in making the decision, So finding that sweet spot or threading that needle between those two things, I think my ethics background has at least caused me to think more deeply about, Susan.
Paul, I have often heard you say that nurses are some of your favorite people. So here's a question thinking about nurses. What role does the oncologist nurse play in these communications? And how do you understand and feel the emotions of the patient?
I have such a long answer to this question, which I can't fully go into. So those of you, I was trained as a physician, having basically ignored nurses throughout training and not really understanding what nurses did. And another thing that my ethics background allowed me to do in the early days of the Fairbanks Center was to get in touch with and listen to bedside nurses and their actual experiences, which was the whole reason we created the program in nursing ethics in the first place, just out of the knowledge that they have these deeply important ethical problems at the bedside. So oncology nurses, are jacks of all trades or Jills of all trades. And in many ways, they, do complex work in the inpatient setting, do extraordinarily complex work involving great technical skill and assessment and emotion and so forth. We've done a whole lot of research on this question of how oncology nurses might become more engaged in helping patients who don't seem to be acting on their prognostic understanding or haven't been given an opportunity to understand. So one of the things I've written and talked about recently is the fact that about 30% of oncologists are just not very good at this. I can show you all of the evidence for that, but I think the empirical evidence suggests that 30% of us are not very good at this. That contributes to patients' late decisions to forego anti-cancer therapy. And I do think that oncology nurses, with all of their skills in relating to patients, communicating their knowledge of cancer, et cetera, would be enormously valuable partners if we could up their freedom to engage in those kinds of discussions. Right now, many of them feel inhibited and for multiple reasons to be able to engage in those discussions.
All right, Paul, this is shifting a little bit to, this is from Shelley Johns. And then I'm going to add in another question to tie in with it from another attendee. So Shelley, first off, starts saying such wise, meaningful, and a compelling talk. When you reflect on all that you have learned and mastered through many years of practice, what's next for your growth and your development? In other words, what are you still hungering to learn and develop or master? And then someone else is asking, can you share a little bit about your own self-care in dealing with this?
Yeah. Oh gosh. Shelley, there are so many things that I could learn just from Shelley. So I'd be happy to learn many of them from you, as Shelley has been one of my great teachers. So one is one of the things that I'm interested in revamping, as it were, is that when you have practiced oncology for a long time, I think doctors in general, probably in every specialty, we develop a lot of shortcuts. Meaning, because patients are sometimes want to talk about this or want to talk about that, we have short encounters and we want to get things done. So we develop actually and the shortcuts often amount to rerouting or re-guiding patients, and that cuts them off. And so I have a desire to find ways back into the ability just to, explore the things that the patient is going through, because I've found those to be the most meaningful interactions that I've had with patients. Part of this is the electronic medical record and the demands of documenting and so forth that everybody knows. So that's one issue. Another thing that I have maybe it's a pie in the sky idea to write a book or a manual about this, sort of related to this talk, that is a practical guide to the large and complex set of communicative tasks that oncologists face, and oncology nurses for that matter face in the practice of oncology. So if I get up the energy, I'm going to try to turn this into a book of some kind. And then cancer has changed. Just the science of cancer has changed dramatically in the 20 years I've been doing this. And I look to my younger colleagues who understand the newer science much better than I do. And I still need to learn a lot of cancer science along the way, because I've not kept up as well as I should. My self-care, exercise, I play music, and my wife, Melissa, and I love to go. She's a musician by training and a physician, as many of you know, and we love to go to music and listen to music.
Thank you, Paul. Here's a beautiful perspective that Devin Ryan wants to share with you. Devin says, I'm a patient living with, so Paul, I'm sorry, you're gonna have to help me with these the cancer of big words. Glioblastoma, diagnosed in February of 2020 and surpassing the average prognosis, which is 12 to 18 months. This lecture was informative and provided me with the perspective from the oncologist point of view and having these difficult conversations with patients. I wish this could be shared with all of the oncologists at IU Health. Thank you, Dr. Helft.
Thank you, Devin. Our fingers are crossed for you. Glioblastoma, Robin.
Thank you. I heard the word before, but seeing it in print and saying it out loud are different things. So someone is talking about now the medical school curriculums, because very little of the medical school curriculum is dedicated to teaching communications in any context, let alone specifically with respect to life-limiting illnesses. Do you think that this is an oversight, and what could be done about the training?
There has been, more attention in the past 2 or 3 decades paid to it than there was for 100 years. So there is some. It tends to get pushed out to more biomedical topics, just because the curriculum is so large and complex for medical school now. It turns out, I personally believe that communication is probably the single most important skill that one can learn, practice, hone, improve, and get better at in the practice of medicine in general. Meaning that surgeons learn to cut and to heal through surgery, and oncologists give chemo, and psychiatrists give medication and counseling and so forth. But if you, to the extent that you can communicate well, every aspect of practice is improved. So informed consent is improved, patient's sense of self can be improved, decisions are better, the patient's quality of life and experience of life-ending illness is better, and so forth. So I do think that it's a neglected area, and it turns out, if you ask me, that this is the most important thing that one could put into the curriculum. I mentioned that it turns out that many of the skills are difficult to teach, and it's not, and the science of communication skills training is actually not that developed, meaning we don't have, I think, a deep, both sort of theoretical framework and a practice framework for teaching and looking at outcomes from communications training. So there's a lot of opportunity there.
Are there ways, especially like our acute care providers, that we can training that they can receive to reduce communication gaps? That was one of the questions, is how can we help our acute care providers? So what kind of trainings are out there?
So, locally, we have several experts involved in a program called IU Talk. And IU Talk has various permutations. The original, or at least one of the original sources for this, was a program that Anthony Back and Walter Bale developed called OncoTalk, which was specific to oncologists. But there have been programs developed for ICU physicians, primary care physicians, and so forth. So I would look first to IU Talk. Most of the trainee fellows, clinical fellows around the organization end up doing a couple days of IU Talk. Robin, our fellows do some of this training in the Ethics Center and so forth. So I would say that that's the best place to start it on the IU campus.
I also know, Paul, that it comes from Vital Talk, and I know that they're doing a lot more of their training virtually, so people can go on the Vital Talk website and see if there are virtual trainings available for them.
Well, and the folks around IU who facilitate the training are excellent, absolutely excellent.
Amazing, yes. Paul, we've had so many different comments and questions that comments that we'll leave for you because people want to send their well wishes. We have maybe time for this last one. Patients have, so thank you for this presentation. Patients having their first consultation, would you recommend having them schedule another visit when it seems like they're overwhelmed or aren't really receptive to talking? In your experience, is this something that patients need?
Yeah, this is such a great suggestion. And I mean, I do try to take advantage of this whenever possible. And of course, it's limited by, your clinic schedule and how much time you have and so forth. But especially for a new diagnosis, patient who needs a complex decision, extremely helpful to have a second conversation, even if it's just a 20 or 25-minute second conversation after the hour that you spend in the first time. Extremely helpful. And it allows patients, to digest the material, to get some of the emotion under control and a little bit less fresh and raw, and then to formulate new questions. And that helps them to ask questions that they feel are most important to them. That is a superb suggestion.
We will make sure for all of you that are sending your well wishes and appreciations that Paul will see these. But Dr. Helft, thank you for the thousands of people that you have taught. We are grateful, and we still have so much to learn also from you. So I'm glad that you're going to continue to teach.
Well, thanks, Robin, and thanks to everybody. And I will see you around.
All right. Bye, everybody. We'll see you next month.
Bye, everyone.